Hello, good afternoon to all, and thank you for meeting us in this fourth session of the Patient and Family Day. I'm Julia Ruiz, one of the local nurses of this, again, virtual EBMT, and I will be co-chairing this session with Natacha Bolaños. This session will be focused on new developments. CAR T cell therapy has become, in the last few years, a promising treatment for some diagnoses. And then we will switch to other diseases, to autoimmune diseases, where we talk about multiple systemic sclerosis, Crohn's diseases, and here transplant and novel indications for these autoimmune diseases that we find that they are challenging because of these large effects that they have and the chronicity. So I will introduce the first speaker, that is Kevin McNutty. He is from Gibraltar, and he will talk about his experience as a patient that has received CAR T cell therapy. The floor is yours, Kevin. Thank you.
Thank you very much for the invitation. Yes, my name is Kevin McNulty. I'm 71 years old and retired after a lifetime in publishing. I was born in the UK, but I'm now living in Gibraltar and have been there since 2008. Historically, I've had an unremarkable health record, no broken bones or hospitalizations, other than the removal of tonsils when I was a child, and a couple of hernia repairs since then. In early 2019, I developed back and hip pain to the left side of my body, which became acute at times and was getting progressively worse. I had lost weight, but I didn't display any other symptoms to suggest there was anything sinister. Tried massage and chiropractor, etc., and eventually had an MRI scan, but that was inconclusive. But a further X-ray suggested that there was some sort of cystic splenic mass that had developed on that side of my body. A further CT scan was followed by biopsies and endoscopies, and concluded a diagnosis in June 2019 of diffuse large B-cell lymphoma, which was at stage 4. I was pretty speedily transferred as a Gibraltar Health Authority sponsored patient to the Royal Marsden Hospital in London. And between September 2019 and January 2020, I received 6 cycles of R-CHOP chemotherapy, plus 2 cycles of methotrexate. I found that final procedure the most testing of all of them. I did have some admissions during the chemo, which was done as an outpatient, and an influenza infection, which slowed things up a bit. However, a subsequent PET scan confirmed that the results after the R-CHOP were positive, although there was still residual disease in the peritoneum area. Radiotherapy was discussed with me and considered, but given the nature of the disease, it was also considered that salvage chemotherapy was a more appropriate treatment prior to a possible consideration of stem grafts. I believe that the intention was that if the salvage therapy achieved remission, then stem cell transplant might be a possibility. Unfortunately, the salvage therapy wasn't successful, and there was, in fact, a local disease progression over that period. I was told then that there was really no point in continuing with this therapy, and that at this stage, autograft would not control the disease. A further PET scan at that time confirmed that the area of residual disease was not an area amenable to biopsy. Well, as you can imagine, this was all rather deflating. However, the option of CAR T therapy was raised, given that I might qualify and that my case would be considered by the relevant authorities in the UK and in Gibraltar. I must confess that at that time I was at a pretty low ebb, and even inquired what would be the outcome if I stopped treatment altogether. The answer of the likelihood of a pretty swift demise concentrated my mind to battle on. I was delighted to learn shortly after that the application had been approved. It was now around about May 2020, 10 months since my first move to London. It was at this stage that things started to move pretty quickly, and I was thoroughly briefed on the complete CAR T procedure, together with timelines for implementation. To me, as a layperson, it seemed extraordinary and sounded more like a Star Wars script than a medical procedure. At the end of May, I presented for collection of T cells. It was a painless process, although on the day my body seemed reluctant to provide blood, so the procedure was quite lengthy. It was 5 or 6 hours to get enough cells. This was followed over the next month by various procedures and tests, including the insertion of a Hickman line into my chest, and 12 sessions of bridging radiotherapy to keep things at bay, and then a final PET scan before I was admitted to hospital. There then followed 5 days of conditioning chemo before the infusion of the CAR T cells. That was an exciting, albeit relatively short and simple procedure. And it was absolutely fine at the start. But after a couple of days, things started to kick in and I ended up in ICU for a few days. Those days are a bit vague in my memory, but I was aware that I didn't require organ support. After my return to the ward, I did suffer from severe diarrhea, which was resolved in a few days. The lengthy treatment over the year had left me pretty frail and fatigued. And with the threat of COVID, it wasn't possible to leave the ward. But I did find it helpful to really force yourself out of bed and attempt 5 or 6 laps of the corridor every morning, just to get some exercise and to have a bit of motivation to get yourself out of bed. And I found that psychologically, this was the most testing time, awaiting the outcome and being monitored on at 4-hourly intervals. On day 28 post-infusion, a PET scan showed good response on the active spleen lesion. And later, it was confirmed that I was clear of the disease at that time. However, the frustration continued and I wasn't allowed to fly back to Gibraltar amid the pandemic with poor blood and immune levels, until finally, on day 54 after infusion, I was given the okay. And during my illness, I lost around 10 kilos, about 12.5% of my body weight, but have gradually increased. I have no significant side effects. A 3-month PET scan and a subsequent 6-month scan in Spain noted no disease present. And the most recent blood test showed good progress, but my immune system is compromised currently. CAR T has been an incredible journey and an outcome from what was a daunting prospect, and I do feel privileged to have been given the opportunity. And in conclusion, I offer my gratitude to all involved at the NHS, and without it sounding like an Oscar speech, particular thanks to Royal Marsden doctors Dima El-Shikawi, Emma Alexander, Emma Nicholson, Carlos Arias, and the Gibraltar Health Authority through Pepe Duran, who all combined to ensure that I've been able to share this remarkable passage with you today. Thank you very much.
Thank you, Kevin. Thank you for sharing with us such a challenging experience and to speak from the top of your heart. Now, I'm delighted to introduce our next speaker, Professor Maria Jose Kersten, Professor of Internal Medicine and Clinical Hematology at the University of Amsterdam. Dr. Kersten performs research in the field of the biology of lymphoma and the development of new treatments with a focus on the care for patients with indolent lymphoma and patients with Waldenström disease. Her research has been awarded by the Dutch Cancer Society, and among other achievements, I want to remark that Dr. Kersten is co-founder of LymCare, a center of expertise for the diagnosis and treatment of patients with lymphoma and myeloma, and of the Dutch, the Lunenburg Lymphoma Phase 1 Consortium, which is a focus on performing early clinical studies in the Netherlands. The floor is yours.
Thank you very much, Natacha, for this kind introduction, and it's quite humbling to follow the impressive story of Kevin McNutty. I will discuss some aspects of CAR T-cell therapy, and because of time, I will restrict it mostly to the treatment of lymphoma and whether or not this is a curative option. So these are my disclosures, and particularly relevant is the fact that I have received research support and also travel grants from several companies that are involved in the manufacturing of CAR T-cells. So as you already heard from the first speaker, for patients with aggressive lymphoma, diffuse large B-cell lymphoma, the first-line treatment consists of a combination of rituximab, which is a monoclonal antibody against an antigen which is present on lymphoma cells, in combination with chemotherapy. So this is the R-CHOP regimen. And with this R-CHOP regimen, patients, approximately 60 to 65% of the patients can be cured already in the first line. The patients who are refractory to R-CHOP or who relapse can receive salvage chemotherapy followed by autologous stem cell transplantation, so transplantation with their own stem cells. But unfortunately, not all patients respond to the salvage treatment, or they show a relapse after the stem cell transplant. And those are the patients who currently have a very poor prognosis, unfortunately. And in this disease area, CAR T-cell clinical trials have been performed. So what are CAR T-cells? The procedure, as you heard, starts with the apheresis, the collection of white blood cells from the patients. And outside the patient, in the lab, these cells are infected usually with a virus, an innocent virus, which can transfer some material into the cell. And with this genetic material, the cells become CAR T cells. All of these T cells of the patient then express a receptor, which is like an umbrella, which it can attach to an antigen on the tumor cells, and they can bind to the tumor cells once they're given back and destroy the tumor cells. So they're sort of like the super soldiers. For CAR T cells in patients with lymphoma and acute lymphoblastic leukemia, the target antigen, so this is the antigen towards which the receptor is made, is CD19. And CD19 is a protein which is expressed on most of the lymphomas and acute lymphoblastic leukemia, but unfortunately also on the normal B cells, which are normal immune cells that are important to produce antibodies. I'll come back to that later. So once the CAR T cells have been made, and this process of manufacturing lasts approximately 4 to 6 weeks, the cells are given back to the patient, and actually after they are given back, they act like a living drug, because inside the patient they again expand, and they also produce cytokines and other small molecules which also attract other immune cells. And together these are important for the anti-tumor response, but also they contribute to the toxicity of the treatment. So there are many CAR T-cell therapy trials worldwide. As you can see, hundreds of trials are open for enrollment. The field is dominated somewhat by the United States and China, and Europe is lagging a little bit behind. And in this slide, you can see that a lot of these CAR T-cell trials are actually in the field of lymphoma and ALL. These are mostly the CD19 CAR T-cell therapy trials, but there are also a lot of trials in the meantime in diseases like multiple myeloma, also myeloid leukemia, and solid tumor, but it has been proven to be more difficult in solid tumors for CAR T-cells to exert their action. At our center, we have contributed to several early phase clinical trials, for example, the ZUMA-1 trial, Juliet trial, and also already phase 3 randomized trials. If you look at the results of CAR T-cell trials in patients with lymphoma, there are 3 large phase 2 trials that have been reported. And in those trials, more than 100 patients per trial were treated. And if you look at the results, you can see that it's approximately 50 to 80% of the patients respond to their CAR T-cell treatment. But it's most important that a complete remission is obtained. And this is seen in approximately 40 to 60% of the patients. Unfortunately, some patients can also relapse following initial success. And all in all, if you look at 10 patients who are treated with CAR T cells, approximately 4 of those 10 patients will achieve a long-term remission. So that's approximately 40%. So we definitely still need to do much better in the future. And this is also demonstrated in this overall survival curve. The ZUMA-1 study is the study which has the longest follow-up of all the CAR T-cell trials, with a median follow-up of 4 years. You can see that approximately 40% of the patients are still alive and in remission after 4 years. So if you look at the patient journey, this is like a simplified scheme. So the cells are collected from the patient with a procedure called leukapheresis. They are then selected and activated outside the patient in the laboratory, infected with the virus, which helps them to express the CAR, the umbrella that can recognize the CD19 antigens. And then 4 to 6 weeks later, they are infused back into the patient. But in real life, it's much more complicated, especially so, of course, for the patient. I'll come back to that later. But also for the CAR T-cell treatment center, because it's a logistically quite challenging progress. During the waiting time, the patient's disease has to be managed. It can be, those patients generally have rapidly progressive lymphoma, and we need to stabilize the disease without causing harm during the waiting period. And after the infusion, we have to look for the side effects and also for the long-term side effects, and of course the response to treatment. So in the patient journey for the patients, there are many uncertainties. First, as you heard from Kevin in the first presentation, you have to be screened and found to be eligible for this treatment. And then during the waiting time, the lymphoma can be rapidly progressive, so it's quite uncertain. Can the infusion go ahead? And after the infusion, there's the risk of side effects, and there's also the question whether or not the treatment will work in your specific case. And the side effects can be quite intense. I'll go into a little bit more detail. So it's very important that a qualified team, a multidisciplinary team, is available at the hospital to tackle these side effects and to coach the patients during this intensive treatment period. So the most important side effects include a sort of cytokine storm. This feels like a heavy infection. Patients have high fever, chills, sometimes low blood pressure, and indeed approximately 20% of the patients have to go to the intensive care unit for a couple of days. But also shortness of breath or organ failure can occur. Then there's neurologic side effects, which can be quite scary because the patient can become confused or even has difficulty speaking or have tremors or even seizures. And we monitor the patients with a writing test and ICE scores to monitor their level of consciousness. This is luckily enough reversible in almost all cases. But also there's low blood cell counts and depletion of the normal B cells, which can lead to serious infections in the first month, but also later during the treatment course. The cytokine release syndrome is seen mostly within a few days after infusion, and the neurologic toxicity occurs a few days later. And most of the side effects are seen in the first 14 days, but for 28 days following the infusion, the patients have to remain in the vicinity of the hospital. As I said, there's intensive collaboration between the nurses, the doctors, but also the ICU, the neurologists, and also the apheresis center, the stem cell lab, and the manufacturer. For the patients outside clinical trials in the Netherlands, as in the UK, we have like a national tumor board where all the cases are discussed, whether or not the patients are eligible, what would be the best bridging treatment, and where can they be treated as close to their home as possible. We also think it's quite important to collect all the data to find out more about why the treatment works for some patients and not for others. And we think it's very important to monitor the quality of life of patients and also their side effects. So we are doing a European project for patient-reported outcomes, where we also use wearables to measure temperature and heart rate, and where we prospectively follow the side effects and also the quality of life. We also look at the burden for the caregivers, because the patients need an informal caregiver to guide them through their treatment path. And the ultimate goal is to provide better support during this intensive treatment period. Another project we are involved in is called the Time to Evolve European project. And also here we aim at giving better information and education and training materials to both the patients and the informal caregivers, but also to the healthcare professionals, so that they can improve the patient journey. And we think we do this together with the patient during the whole process to make this a patient-centered, collaborative approach. So in conclusion, I think at the moment CAR T-cell therapy is already standard of care for a subgroup of patients with diffuse large B-cell lymphoma, and approximately 40% of those patients show long-term benefit. And the results in the real world are similar to the results in the clinical trials. We don't know yet whether CAR T-cells might be better already in the second line. The studies have been done, but there are no results. But there are still many questions to be answered. So we need to improve the efficacy, have better and safer CAR T-cells, and we should have good selection of patients who can benefit and better manage the toxicity. And there's also an issue of access throughout the whole of Europe. Because it's not in the same way accessible in all countries yet. There are also other indications for CAR T-cell therapy. For acute lymphoblastic leukemia, this is already also standard of care for young pediatric and young adult patients. And other types of lymphoma, there's already FDA approval, but not yet EMA approval. And as I said, also for AML and solid tumors, there are many clinical trials, and multiple myeloma is the next indication, which will be also FDA approved probably this year. So I would like to end to say that it really takes a village in your CAR T-cell treatment center to treat the patient and to help them with the best possible care during this quite intensive treatment course. And I'll be happy to take questions later.
Thank you, Mary Jose, for your presentation. And I would like to remind all the attendees that you can introduce the questions in the for the later question and answers at the end of the presentations. And you can already submit all the questions that you would like to do to the presenters. I will now introduce John Snowden. He is consultant hematologist and director of BMT at Sheffield Teaching Hospitals. He is the current EBMT secretary and a member of the Autoimmune Disease Working Party, and he will talk us about the transplant and novel indications for autoimmune disease. The floor is yours, John. Thank you.
And I'll just, can you see my first slide okay?
Yes.
Thank you very much, everybody, and it's a privilege to be invited to the EBMT Patient, Family and Donor Day. And I'm just going to briefly run through what's happened in the last several years, or perhaps it's a few decades now, for autoimmune diseases. And I'll be here to answer some questions on novel indications, but I'll just show you my disclosures, and you think from the various types of international and national media that this is a very new treatment. This is something that was highlighted by the BBC in the UK a couple of years ago when our randomized controlled trial was published. It was also kind of sensationalized as well as a stem cell miracle. But I think the truth is somewhere between. I think it's true that this has been a significant advance in transplant practice. It's also been an advance in the treatment of diseases like multiple sclerosis and systemic sclerosis. And in fact, autoimmune diseases are the quickest, the fastest growing area of transplantation for autologous transplants worldwide. But we have to put it into context. This it is only 2% of all transplants, so this is quite a specialized field, and it's certainly not a treatment for every patient with MS or other autoimmune diseases. However, the treatments have presented an exciting new avenue for patients with autoimmune diseases. So this is just a slide summarizing what autoimmune diseases are. They're relatively common compared with a lot of the other diseases we transplant. 5 to 8% of the population. MS occurs in 1 in 1,000 patients, 1 in 1,000 population rather, whereas compared with AML or myeloma, it's relatively rare. Types of disease. So not all autoimmune diseases are severe, but some are very disabling and life-threatening, and cure remains elusive. So almost all severe autoimmune disease patients require long-term therapy, and the impact on the patient is not just of the autoimmune disease, but it's also of the treatment. You can imagine there's a lot of impact from chronic steroid or immunosuppressant treatment, as well as the impact of the disease. The costs are high, not just the drugs that need to be given sometimes year after year, but the cost on the individual through loss of work, disability, impact on the family, and there's an impact on society from autoimmune diseases. So there's been for a long time a desire for a one-off intensive means of disease control in autoimmune diseases, and the concept of using transplant, hematopoietic transplant in autoimmune disease is not new. It's 4 decades old. It was thought about in the 1970s and 80s through animal model experiments, but it was first really looked at in 1995 when the first patients were treated with autologous transplant, specifically for an autoimmune disease. That it was multiple sclerosis mainly. And not long after that, the EBMT formed its autoimmune diseases working party, developed a part of the registry, which became known as the Autoimmune Diseases Database, and then many guidelines and studies have followed since. The activity has been predominantly in autologous transplantation. Allogeneic transplantation does go on, but the risks are generally too high, particularly outside of pediatrics, where children can tolerate this type of treatment better. But allogeneic transplant is probably more effective because it provides complete immune replacement. In contrast, autologous transplantation provides what's been often described as an immune reboot for autoimmune diseases. You'll be familiar with this pathway. It's a standard autologous transplant pathway where you have the chemotherapy and the GCSF to mobilize the stem cells. They're then frozen down, and then the patients have conditioning chemotherapy, and then they get the stem cells thawed and reinfused, and then go through the period of neutrophil and lymphocyte recovery. But what happens after a transplant in autoimmune diseases is that you do get an immune reboot. You get a shower of all these different sorts of cells that basically, having wiped the slate of the dysfunctional immune system, you get all these new cells produced, which in some diseases can result in a very effective and long period of remission. This is some data from the Autoimmune Diseases Database. It shows that around about 3,500 patients have received a transplant for an autoimmune disease. As you can see, virtually all, over 90%, are autologous transplants. There are a number of allogeneic transplants. It's predominantly in pediatrics those have been performed. And some patients have had second and third transplants when they've had a good response to the first autologous transplant. But most patients have been treated for multiple sclerosis. That's been the number one indication. And then the other indications have been these connective tissue diseases, particularly systemic sclerosis, also lupus. In the past, quite a large number of patients were treated for arthritis, but that's sort of less common now because the treatments for arthritis have got better. Inflammatory bowel disease, Crohn's disease, has been an ongoing indication for autologous stem cell transplantation. And then you've got these other rarer conditions that have been an indication for autologous transplant. Even insulin-dependent diabetes, when it's in that honeymoon phase, can be intercepted with autologous stem cell transplantation to produce a remission. But the main indications are multiple sclerosis and systemic sclerosis. This is a complex graph. It does show that this work all started back in 1995, and then what happened, the interest grew, but then we've got this long period where biological therapies in autoimmune diseases started to develop. So there were very strong competitors for transplantation. But I think at the end of the day, there were patients that did not respond to these biological therapies. So in the last several years, transplantation has grown and grown in some conditions where biological therapies have had a limited benefit. This is a complex graph, but the blue is the multiple sclerosis, the green is the systemic sclerosis, the red is the Crohn's disease, and these other indications are relatively rare. But you can see that there has been a growth, particularly in multiple sclerosis and systemic sclerosis. To the extent that we now look upon multiple sclerosis and systemic sclerosis in our EBMT indications as standard of care indications for transplant, because they're supported by randomized controlled trials. So I'm going to talk a little bit more about MS. and systemic sclerosis. And MS is a biphasic disease. You have this inflammatory phase that is called relapsing remitting. It is then followed by a secondary progressive phase, and it's really in the inflammatory relapsing remitting phase that you can make a big difference to the outcomes with either drugs or autologous transplant. In the inflammatory phase, you get these enhancing lesions, which are active areas of inflammation that destroy the brain and the spinal cord and result in periods of disability that often partly recover. But if you get those inflammatory lesions happening again and again, you end up with the degenerative phase, which is irreversible and progressive. As you can see in this slide, if you do an autologous transplant when the patient's in this inflammatory phase, you can take away these inflammatory lesions and often take them away for very long periods, maybe even permanently. If you do a transplant in the progressive phase, if there's no inflammation, there's no response, even if you use the most intensive forms of transplant conditioning containing radiation or very high dose chemotherapy. So it's important to be in the right phase of the disease, the inflammatory relapsing remitting phase of the disease, if patients are going to be considered for transplant. They of course have to be severe enough, and they have to have resisted at least first line treatments. Neurologists are very good at identifying these patients that are going to do badly, and this is a guideline that we wrote with our neurologists and the EBMT autoimmune diseases working party. Just a few mentions about systemic sclerosis. It's a rare disease. It's associated with inflammation of the skin, lungs, heart, and it affects the kidneys. It's associated with fibrosis and scarring, and it's often got a poor prognosis compared with other inflammatory diseases in terms of a limited prognosis and life expectancy. Transplant is effective at reducing that skin inflammation and fibrosis. Not only in the skin, it can successfully reduce the inflammation and the fibrosis in the lungs, which is the feature that results in the poor prognosis in some patients. And there are 3 randomized controlled trials in systemic sclerosis that support improved overall survival and improved progression-free survival in systemic sclerosis with a transplant. And the International Society, which covers rheumatological disorders, the European League Against Rheumatism, recommends transplant to treat skin and lung disease in systemic sclerosis. So with time, in autoimmune diseases, we're getting better. We're picking the right patients. We're getting more and more experience, and there's a better balance between the safety and the efficacy and the toxicity of conditioning regimens. So we're treating patients more effectively for better outcomes. How do we improve this evidence base? We improve it with randomized controlled trials, and we also do these prospective, non-interventional and retrospective studies involving the EBMT database. We also produce guidelines and recommendations. This is just a slide summarizing the number of mainly randomized controlled trials in multiple sclerosis that are ongoing across the world to really establish the treatment as a standard of care and fine-tune the regimens. Those will, I think, largely resume now that the COVID pandemic has started to settle. So education is crucial, not just for the specialist clinicians, but also for the non-specialist clinicians, the GPs and other clinical staff, and also for patients and carers. We've worked very closely over the years with the Patient Advocacy Committee, particularly with Bregi Verhoeven, and others to produce guidelines that are plainly worded for patients and also non-specialists. We produced these guidelines very recently for rehabilitation after autologous stem cell transplantation in multiple sclerosis. Again, Breggy, but was very much involved with this. So in conclusion, autologous transplant is evolving into a standard treatment in some autoimmune diseases, and it's being considered alongside modern therapy for autoimmune diseases. The future depends on the dynamic with the standard of care therapies, and it also depends on the acceptance by the national and international specialist communities. Further studies are necessary, and we must keep on performing the randomized controlled trials and the retrospective and prospective database analyses. We need to work out how we're going to navigate through COVID. We need to define the health economic benefits. Allogeneic transplantation is much more niche, it's rarer, but it's might have a role, especially in pediatric diseases with a strong genetic component. So I'll leave it there with an acknowledgement to the Autoimmune Diseases Working Party and the JC Committee. I've been involved with both of those over my time with EBMT. This is Sheffield, and as you can see, it's in the middle of the UK. This is my hospital, and this is the cityscape, and this is some nice countryside near Sheffield, where it's been a joy to take a bit of a break during the lockdown in a self-isolated way. Thank you very much for listening, and I'll be delighted to take questions.
Thank you. Thank you very much, John, for such an interesting presentation. And I would like to jump directly into a question for you. Research conducted by patient advocacy groups shows that there are many gaps and that patients in general do not receive, or they say they do not receive, adequate levels of information. So I would like to ask you, how do you assess the patient's communication needs and how you manage the gaps they may have?
Okay, well, generally, it's good to have lots of face-to-face discussions, and I'm very well supported by clinical nurse specialists who sit down with me with patients as a matter of principle in all patients, whatever their diagnosis. And often when you've got dedicated transplant nurse specialists, they can then go on to have further discussions with patients. And I always copy my clinic letters to patients, and we use those as a basis for discussion with the patients that the nurse specialist can refer to and share with the patient at later time points. Every patient's an individual, so we do need to tailor the time and the level of advice to each patient individually. With respect to autoimmune diseases and such diseases such as MS, yes, it's important to have other written information, and that's partly why we developed that guideline, which involved Brecky and other members of the Autoimmune Diseases Working Party. It was published in Bone Marrow Transplantation, which is the EBMT scientific journal, but it was written in a very accessible top type of English. It wasn't written in a technical type of jargon. So that is a document that would help, I think, a lot of patients that are considering transplant for autoimmune disease. I mean, one big issue in the transplant for autoimmune disease is the issue of patients traveling between countries. In principle, there's nothing wrong with that. I mean, ideally, patients should be treated close to home, I think. But sometimes patients have to travel, and it's very important, if they're going to travel, then they get the right information. They know what they're what they're going to be facing, the pathway they're going down. So that kind of document was really aimed at patients and also their carers, whether that be family carers or friends, and also at their GPs. I mean, on the whole, primary care or GP will not know so much about transplantation and these very specialized areas. And, that document was there for them as well. So that's how we kind of approach the challenge or the routine normality of patient counselling and education.
Thank you, John. I would now like to ask Kevin, also following about the information. Were all options discussed in advance before CAR T cell therapy? How do you find that patients participate in decision making? Because there may be also relapse after CAR T or the loss of the CAR T. And how did they cover all this information with you?
Okay, I'd been through 10 months of chemo with limited success, and in fact progression in local disease. So as I said before, I was at a pretty low ebb, and after being told that stem cell, which had been discussed with me, was now not really on the table, to hear that there was another option, CAR T, was exciting. I mean, there's two emotions that you go through when you're at such a low ebb. I mean, one is fear and the other's hope. And when someone gives you the opportunity of hope with a new option, it's very exciting. So I was very positive and very confident about, excited although apprehensive, but I was very confident in what I was being offered and how it had been fully explained to me, how it worked, what the opportunities were, what the outcomes were likely to be. Nothing was held back. So I fully understood what I was getting into and accepted it with both hands.
Okay, thank you, Kevin. This question is for Maria Jose about the application that you have talked about to monitor quality of life and side effects based on the patient-reported outcomes. At which stage is it now, and when will this start? And how do you expect that the responses will be of patients and carers? If there will be a great response, or if you find there may be any difficulties when using the apps, and if you have explored this.
Thank you. So basically, we are working on this project, and it's a European project. So we aim to do this also in other languages and other countries. And obviously, that's an obstacle to have this translated also in other languages. We are doing a pilot experiment at our own center now with the questionnaires for the short-term side effects and also for the long-term side effects. And there's obviously several factors that we have to look at. For example, patients with low literacy or patients who are older and are not used to work with apps. There it's probably still more feasible to use printed questionnaires. So I think we should do this in a patient-tailored fashion, and our aim is really to involve patients at all stages of this research project. We are actually very curious also how patients at the moment find their information on the internet or through the communication with their healthcare providers, and also will aim at having like a sort of central website together with the European Cancer Patient Coalition to have one very good website where non-branded information is available in several languages.
Thank you very much for that explanation. And my next question will go to John again. I wonder, in multiple sclerosis or Crohn's disease, is the transplant considered as a last line treatment after everything else has failed? And if you could tell us if there are clinical trials comparing the transplant against other therapies like biological treatments or so.
Okay, I think as a general principle, it is much better to identify the patients early on in their disease course than waiting until they've failed all treatments. The reason being is that the disease, I think, is far more manageable in an earlier time point, and also further down the line, the patients are much less fit for transplant. However, you don't want to treat them too early, and they need to be identified as those patients that are destined to do badly by the disease specialist. So, for example, in multiple sclerosis, you would try one or two standard treatments, I think, but the neurologist would know that certain types of patients that are becoming disabled very recurrently or very quickly, accumulating disability, are those patients that aren't really going to respond to other lines of standard treatment. And it's those patients that I think need to be picked up relatively early before they become too disabled or compromised for transplant. So I think we're much better at identifying those poor prognosis patients with autoimmune diseases. Now, in the early days, yes, this is 20 years ago, patients who had failed everything got offered transplant. They weren't the best patients, they weren't the fittest patients. But nowadays, I think if you work closely with a disease specialist, they'll have a proportion of these patients in their practice that have got very tough disease, very poor prognosis, and they can identify them. And then at those earlier time points, that you can start having those conversations regarding transplant. The answer to the other questions are yes, there are in multiple sclerosis, particularly, and I showed them on one of my slides. I couldn't spend very long on it, but there are randomized controlled trials of autologous stem cell transplant versus other standard of care treatments, so the biological treatments. We have one in the UK called STAR-MS. There's one in Scandinavia and the Netherlands called RAM-MS. There's one mainly in the US called BEAT-MS. And there's several elsewhere, including Germany, Italy. There are trials that are, some of which were started before COVID, they've been put on hold, but and some of which are just to get going as COVID settles. So I'd say there'd be quite a lot of data coming through over the next several years when those trials start to recruit and complete and then report about how transplant matches up against the standard of care biological treatments in MS. In relation to other diseases, there is one systemic sclerosis trial, which is a randomized controlled trial open, and it's based around the Netherlands.
Thank you, John. There is another question for you about that says that in many countries, the transplant is not a standard for multiple sclerosis and therefore not reimbursed. So what can be done to improve the situation for these patients?
I'm glad this question's been asked because it's a very important question, and it does vary very significantly between the health authorities and health services around Europe. I think that the best answer is that is to produce more evidence, more randomized controlled trial data, more high quality data. Sometimes different health authorities require more evidence, and unfortunately, that's been the case in some countries more than others. I think you'll know that in the Netherlands this has been an issue, whereas I think in the UK and some other countries, Italy, I think there's been less issue with reimbursement. We did have, however, issues with Scotland and Wales, and I guess I had to work with the Scottish and the Welsh health authorities to provide them with the necessary evidence and the health economic analyses that needed to be done in order for them to be funded. But yes, we need to all work together as a community. Germany is another country where it's not been so easy to get reimbursement, but I think that's about the EBMT working effectively across borders, and hopefully we'll solve this problem, and at the same time we'll all be trying to answer the scientific and the clinical questions through good randomized controlled trials.
Thank you. We have only 5 minutes left. However, I would like to go into a question for Dr. Maria Jose Kersten. Considering everything that Kevin has explained about the challenges for quality of life, I wonder, Dr. Kersten, if you could explain more about the need to follow up on the quality of life for patients treated with CAR T cell therapy.
Thank you for that question. We think it's extremely important because not a lot is known at the moment. So it's a relatively new treatment with short-term side effects, which can be quite severe, and also especially the neurologic side effects. And we don't know a lot yet how that affects the quality of life in the long term. So I think it's a very important area for research. Also, because as Kevin also alluded to, the time in the intensive care unit can lead to some psychological problems in the long term. So, and also the burden of care for the caregiver can be quite severe. So we think that's an important area to collect more data and use these data to improve the patient journey.
Thank you, Maria Jose. I would like to ask Kevin about the same question. How do you find the follow-up of the quality of life and the pathway, and how this can help you? And what do you think that is still needed in this question?
Quality of life. I don't feel any different now to how I did, a couple of years ago before I suffered the disease and before I had all this treatment. I think, as I mentioned earlier, I think the only thing that it's left me with currently, and this is 6 months after CAR T, is still some level of fatigue, but that's improving all the time. I don't feel that other aspects of my life have been affected dramatically at all, if anything. But one of the things that hasn't been mentioned, and I think it is important, is the people within the hospital are such a critical element in success. When you're in hospital and it's COVID time and the ward is locked and you can't go anywhere and no one can come and see you, those doctors and nurses on hand are absolutely critical to the way that you perform. And I just think it's something that hasn't been mentioned, and I just wanted to make sure we got that across today.
Okay, thank you, Kevin. So we are coming to the end of this session, and I will wrap up now with some conclusions. First of all, thank you, Kevin. Thank you, John. Thank you, Mary Jose, for your presentations and for sharing the experience here today with all. And yes, I would like to keep in mind what Kevin has transmitted now for the last talk, that he has said that it's very important for the support that is being given in the hospitals, mostly in this time when there is some lockdown and not all visitors are permitted, and the need of support is important. So we, as healthcare professionals, have to keep this in mind. Also, I would like to remind that it's important to hear the voice of the patients, the voice of the families, and this we will have it between the patient outcome reports. Important for us to know what's going on and to give answers to those questions that are being, and to know how our treatments are impacting in patients and in their families in the long term also. So thank you all, and I hope you enjoy the rest of the Patient and Family Day together. Thank you all for attending. Goodbye.
Bye-bye.